Hey there, I'm back for more. Now we're going to talk about the assessment of cardiovascular function. This is a very, very brief high-level overview of cardiovascular function. If you need to review your anatomy and physiology because you don't know it, I highly suggest you do go back and do that because it will make so much more sense when you do so. Here's your objectives for this lecture. You should be able to speak to them at the end of this. If you can't listen to this and know, go back and read your book, and don't forget the glossaries and definitions. So here's the overview of anatomy and physiology of the heart. Pause the video if you need to review this in your book. These are the three layers of the heart muscle: endo, myo, epi, cardium. 4 chambers. You have a left and right atrium and a left and right ventricle. Then you have the atrioventricular valves, which are the tricuspid and mitral valves, the semilunar valves, which include aortic and pulmonic, all the coronary arteries, the cardiac conduction system, and the cardiac hemodynamics that happen. Both of these at the end will be more in depth in blocks 2 and 4. So now let's go to how the blood flows through the heart. So remember, you have the inferior vena cava and the superior vena cava. They carry the deoxygenated blood from the veins in your body back to the heart and enter to the right atrium, which is the top right of the heart's 4 valves. The right atrium is responsible for receiving deoxygenated blood. Note that it's blue. The right atrium then sends deoxygenated blood to the right ventricle. This blood travels through this tricuspid valve right here, enters the right ventricle. So, note that the ventricles are much larger than the atria in the heart. Also note that the muscle of this part of this ventricle is not nearly as thick as the left. And I can tell you why right now, if you don't remember. It's because the right ventricle only is carrying that deoxygenated blood to the lungs, which are right there. So it doesn't have to work as hard as the left, right? Or, I'm sorry, yeah, the left. Let's see. This blood goes to the tricuspid, to the right ventricle, and then the right ventricle transfers that deoxygenated blood to the lungs through, and this is important to remember, the pulmonary valve, and then, this is the pulmonary valve, to the pulmonary artery. This is the part I want you to remember. Remember that the pulmonary artery carries deoxygenated blood. It's the only artery in our body to carry deoxygenated blood. So, it's now in the lungs. Once the lungs oxygenate the blood goes through the pulmonary veins, which are over here. So, note, now it's oxygenated and it's going through veins. So, this is, again, a differentiator because most of our veins in our body carry deoxygenated blood, but not when they're going to the lungs and away. It's the opposite. Deoxygenated blood from the heart to the lungs, reoxygenate in the lungs, carry it back through the veins to the left atria, or atrium. And then the blood it goes through the mitral valve. Mitral valve is right here, which allows the blood to pass to the left ventricle when it's open. The mitral valve helps to manage the flow of blood to the left ventricle, ensuring that the blood flows in the correct direction. So if you have mitral valve prolapse or regurgitation, see how you could have some issues with blood flow through the heart anytime you have any type of valve issues. But I feel like the mitral valve is one that you will hear like a murmur there, and that's because it gets a pretty good workout. So after the oxygenated blood passes through the aortic valve, let's see, wait a minute. Wait a minute. It goes through the mitral valve, and then it goes out through the aortic valve to the aorta. So it leaves the left ventricle via the aortic valve to the aortic arch and out to the body. So this is very thick muscle, and it tends to get thicker as life goes on or as we have heart issues, because our body has to work so much harder, or the heart has to work so much harder to pump oxygenated blood out to the system, to the body. So this is the area of the heart that tends to fail first. It has to work the hardest, so that sort of makes sense. Hopefully what I said made sense. If not, please review your anatomy and physiology. Your electrical conduction system, basically, it is the heart initiating, responding, and transmitting electrical impulses. And so the basic heart rate is set by the SA node. It sets the automaticity. It's automatic. Then you have your AB nodes, Purkinje fibers, and the bundle of His. All of those work throughout the heart to send electrical impulses and make it contract. Without the system, the contractions that occur during cardiac cycles would not happen. Things that you need to recognize terms-wise is depolarization, repolarization, and refractory periods. Just pretty much know, I really want you to understand that all of these electrical impulses happen because of your electrolytes. So notice depolarization. Influx of sodium into the cell while potassium exits the cell. Then it repolarizes, which returns the cell to a resting state, and that is caused by reentry of potassium while sodium exits. So sodium and potassium might be important to your heart's ability to contract. We're not going to test you on the action potential of the heart. Really what we need you to see is that there's a process of polarization that has to occur for contractions in the heart muscle to occur. Most of that, you're going to go way more in depth in blocks 2 and 4. I think in block 1, the biggest thing you need to understand is that this is why we care so much about electrolytes. We've talked about how different ones affect muscle and how potassium is critical to heart rhythms and your heart working appropriately. This is part of why. So just understand there's an exchange of electrolytes occurring as depolarization and repolarization occur, and that assists with the contraction, and we need to have proper levels of electrolytes to assist the process. Make sure you know your lab values that we gave you a couple weeks ago to ensure that you're able to answer questions about your electrolytes. The cardiac cycle refers to the things that occur in the heart from the beginning of one heartbeat to the next. So the number of cycles depends on the patient's heart rate. Each cycle has 3 major sequential events. You have diastole, and that is the phase of the heartbeat when the heart muscle relaxes and allows the chambers to fill with blood. Atrial systole is the contraction of cardiac muscle cells on both the left and right atria after electrical stimulation and conduction across the chambers. It starts at the beginning of a heartbeat and ends when another heartbeat begins. So it's from the end of a heartbeat to the beginning of the next. The systole causes the pumping of blood in the aorta and the pulmonary trunk. So systole is where it's resting, basically. And then you have ventricular systole. Both ventricles contract, and blood is either going to the lungs via the pulmonary trunk, or it's going out to the body via the aorta. This little bike talks about preload, contractility, this is your heart rate, and afterload. I think we go into that a little bit more later. Cardiac output is definitely, you need to know this, how much blood the heart can pump in 1 minute. And so it's stroke volume times your heart rate. Stroke volume is the amount of blood the heart sends to the body in one heartbeat. And that does vary based on how hard the heart muscles have to work and the force they need to use to push the blood out to the body. Stroke volume can go up or down based on the patient's heart health and whether the patient is at rest or moving. And then the heart rate is the number of heartbeats per minute. We already talked about normal is 60 to 100, and it can go up or down whether the patient is resting or exercising. So cardiac output is expressed in liters per minute, and it is the amount of blood the heart pumps in 1 minute. The heart is just one part of the much larger cardiovascular system. However, and the amount of blood it pumps is dependent on 4 determinants of cardiac output, and they include heart rate, contractility, preload, and afterload. So that was your cardiac output, stroke volume times the heart rate. Now we need to go over preload and afterload, I'm pretty sure. So stroke volume, we already talked about. Preload is the degree of stretch of cardiac muscle fibers at the end of diastole. So it's in there and it's relaxed. Afterload is the resistance to the ejection of blood from the ventricle. Contractility is the ability of cardiac muscle to shorten in response to electrical impulse. So all of those are going to affect how your heart is working. And remember afterload. Remember how I talked about we do the echocardiogram, or we call it an echo a lot of times. And we come up with this ejection fraction, which tells us how much blood is pumped out of the left ventricle and out to the body with every contraction. And normal is 60 to 65%. So ejection fraction and afterload are basically the same thing. Here's some different things that influence your cardiac output. Things that control the heart rate, so your autonomic nervous system and your baroreceptors. The sympathetic nervous system and the parasympathetic nervous system make up the autonomic nervous system. The sympathetic nervous system releases hormones like catecholamines, epinephrine, and norepinephrine to accelerate the heart rate. The autonomic nervous system controls all automatic body functions, such as breathing, heart rate, blood pressure, sweating, mouth watering or salivating, and the movement of food through the intestines, called peristalsis. Sympathetic nervous system activation will stimulate the SA and AV nodes to increase the heart rate, which will increase cardiac output. Parasympathetic nervous system activation will conversely act on the SA and AV nodes to decrease the heart rate, which will decrease cardiac output. Baroreceptors are special nerve cells or receptors that sense blood pressure. And they do that in the walls of the blood vessels and how much they're stretching. That information is sent from the baroreceptors to the brain to help keep blood pressure balanced. Preload and the Frank-Starling relationship is based on the link between the initial length of myocardial fibers and the force generated by contraction. There is a predictable relationship between the length between the sarcomeres and the tension of the muscle fibers. The left ventricular performance curves relate preload, measured as left ventricular end diastolic volume, so end diastolic volume, or pressure. This is like so wordy, I don't even know what I'm reading. Afterload, also known as the systemic vascular resistance, is the amount of resistance the heart must overcome to open the aortic valve and push the blood volume out into the systemic circulation. So, things that can affect preload. Let's talk about this in English. Blah, blah. I feel like the biggest things here are how are the muscles working in general, and how are the valves working. So this is the part where you're bringing the blood into the heart. So how much room is in there, and how are those valves working to let the blood move in. Now let's go to the next slide. That is contractility. Contractility of the heart muscle is where it's pumping blood. And cardiac contractility is determined by the interaction between intracellular calcium concentration and the myofilament cross-bridge cycling. A decreased cardiac contractility is the hallmark of the clinical condition called myocardial failure, which can result from coronary artery disease, myocardial ischemia, myocardial infarction, myocarditis, toxins, or electrolyte imbalances. Myocardial failure impairs the pumping ability of one or both ventricles. So, those were all kind of big words. Hopefully you know them all. Coronary artery disease, that's where the arteries in the heart are occluded. Myocardial ischemia is there's not enough blood getting to the heart or a portion of the heart. Myocardial infarction, you have enough of a blockage that you're having death of the tissue. So that is a heart attack, and time is muscle. Myocarditis is an infection of the myocardium. Toxins can affect the heart. Those could be medications or electrolyte imbalances, which again is why our electrolytes are so important to keep in the normal range. The physical exam of the cardiovascular system involves, oh, you know what we didn't talk about? Where's afterload? Oh, there it is. There's not very much there, but I feel like afterload is kind of a big deal. What can affect afterload? How about the left ventricle is stretched out and not working or pumping effectively, so it's not pushing the blood out. And another huge factor of afterload is how much plaque and calcium buildup do you have inside of your arteries, especially as we age. Think of your body as an old house. When you move into your house, the plumbing might have 2-inch pipes. I don't know what they really are. But now your body is your house is 70 years old. How much gunk is built up in those pipes, and how often do you have to call the plumber? Think of the cardiologist as the plumber and the electrician. So you have one type of a cardiologist that is going to help you with your electrical conduction through the heart. And then you have another type of cardiologist that helps with the plumbing. So if you have a bunch of stiff, non-compliant blood vessels that don't push the blood effectively either back to the heart or out to the body after it's been in the heart, then you have a more difficult time pushing the blood out because those blood vessels are not going to stretch and they have buildup in them. So the heart has to work a lot harder. So that is the afterload, and that is your systemic vascular resistance. And then you can have pulmonary vascular resistance as well from pulmonary hypertension. Hypertension is a big factor in this as well. All right. Contractility is increased by catecholamines, the SNS. I'm having a mental block right now. You know what it is. It's up the nervous system. I'm having an issue. It's because I'm on my third video of the day. I just can't anymore. Talk amongst yourselves while I go back. Goodness. I just can't think of that first S. Y'all know what it is. It was in there somewhere. SNS. I cannot believe I can't think of the word. Anyway, I don't know. And now I've got to look again somewhere else because I got to know. I'm going to pause. Stand by. Okay. Sympathetic. Thank you for your sympathy for my lack of finding words, also known as, I don't know, because I can't think of words right now. Increased contractility results in increased stroke volume. Decreased by, so contractility is decreased by hypoxemia, which is a decrease in the amount of oxygen in the blood. Acidosis, which we'll learn about later in future blocks, and certain medications. So now we're going to finally get into the nursing part of cardiac. A physical exam of the cardiovascular system involves the interpretation of vital signs, inspection, palpation, and auscultation of heart sounds as you're evaluating for sufficient perfusion and cardiac output. A full health history is obtained. Demographic information, familiar history, genetic history, cultural and social factors, and risk factors. So we know that some of our risk factors are modifiable and some are not. So begin by inspecting the general appearance of the patient. Then you can move on to looking at the skin. Look for jugular vein distension, the skin color, warmth, sensation, edema, heart tones, cap refill, pulses, nails, mouth, neck, and extremities. The objective assessment might indicate increased weight on vital signs, visualization of jugular venous distension at the neck, auscultation of fine crackles in the lungs, and inspection to reveal significant lower extremity edema. Risk factors for cardiovascular disease, which includes heart disease and stroke, are classified as non-modifiable or modifiable. Non-modifiable risk factors cannot be controlled. And some leading risk factors for heart disease and stroke are high blood pressure, high low-density lipoprotein, or LDL, which is one of our cholesterols, diabetes, smoking, and secondhand smoke exposure, obesity, unhealthy diet, and physical inactivity. I feel like we probably know all of those already. The only one that I tend to get confused is, do I want high LDL or high HDL? But I want happy cholesterol, so I want HDL, whereas the low is a loser. I don't want that loser. So you want your HDL to be a higher number, and you want your LDL to be a low number. Sometimes it is the opposite for many people. Some of your modifiable risk factors that can be controlled or changed. High cholesterol, high blood pressure, smoking, diabetes, obesity, physical inactivity, and poor nutrition. So all of those are within our, I seriously need to stop recording. I can't talk to you guys. Aphasia, there's that word. They're within our power to make changes to our lifestyles we can lower our A1C. We can have better control of our type 1 diabetes by checking our blood sugar and taking our medications and improving our diets. We can lower our blood pressure through exercise and through healthy eating and through taking the medications we're supposed to take. which, by the way, blood pressure meds are the #1 most not taken medications by our patients. So, what do you think that means for nurses? We need to do a lot of education. And if it's your family that you're educating, they're probably not going to listen to you. Here's our non-modifiable factors: gender, race, family history, and age. So some other things that we look at include past family history, and social history. We look at medications the patient is taking or has taken, what their diet typically looks like, what are they eating, how's their elimination pattern, do they exercise on a regular basis, or are they sedentary? Like, what kind of job do you do? Are you sitting at a desk all day, or are you working 12-hour shifts on the floor? What's your stress level? Speaking of 12-hour shifts, are you exercising? Are you going to the gym? Are you getting your heart rate up for 30 minutes at least? I don't know what the recommendation is anymore. 3 to 5 days a week. How are your sleep habits? You know, another risk factor that's not in here that can cause heart issues is, seriously, I have to go home now. It is obstructive sleep apnea. Sleep apnea that is not treated. How's your ability to handle stress? How are you handling that stress? What are your coping mechanisms? Do you have healthy roles in relationships? All of these things. So what are the symptoms of cardiovascular disease? All those things that are listed on this slide. Chest pain or discomfort, remember that is due to perfusion issues. It's not getting adequate oxygen, causes pain. You could have pain or discomfort in other areas of the upper body. Why? Same reason. Maybe they have shortness of breath / dyspnea. Peripheral edema, weight gain, and abdominal distension. Palpitations, unusual fatigue, dizziness, syncope, which is fainting, or a change in level of consciousness, all due to inadequate perfusion. So it could be the blood pressure is causing it. It could be medications are causing it. In any case, they're not getting adequate oxygenation to the rest of the body due to the heart or the cardiovascular system, not just the heart, lungs, cardiovascular, all of it combined usually. So what lab tests can we take, or what do we anticipate the doctor might order? By the way, I emailed all of you guys that concept map. Please use it and fill it out, because a lot of the stuff I'm talking about right now goes right on that one pager, and it'll help you remember this stuff. So we're going to look for a lipid panel, which is going to say what our cholesterol panel is, basically. And then C-reactive protein and any other protein markers that might be ordered. The C-reactive protein tells us what the inflammation looks like in the body. And inflammation can lead to heart disease. During a heart attack, the heart muscle cells die and release proteins into the bloodstream. Your heart releases cardiac enzymes when there's heart damage or stress due to low oxygen. So if somebody's exhibiting signs of a heart attack, expect and anticipate we're going to be doing a troponin level, and that's usually done 3 times every 6 hours. So 1 time times, I guess 3 times, and that's at 1 hour, at 6 hours, at 12 hours. I don't know. Again, I can't talk. Expect that to be every 6 hours times 3. Sometimes we do a CPK because those levels also rise after a heart attack. And elevated heart enzyme levels can also indicate acute coronary syndrome or ischemia. Acute coronary syndrome, I feel like that is where you have angina or angina. There's also a connection between CBC with heart health. A complete blood count result can help a cardiologist detect complications of the pumping ability of the heart. Other laboratory tests that help with diagnosis include cardiac biomarkers, blood chemistry panels, hematology, coagulation studies. Oh, here's a big one for heart failure, and that's B as in boy, N as in Nancy, P as in Paul, brain natriuretic peptides. That level will be elevated in heart failure. I already said C-reactive protein and homocysteine. So those are some lab tests you can expect to be run. Here's your 12 lead. So if somebody comes in with cardiovascular symptoms, we better have them on a 12 lead right away. And then after that, if they get placed in the hospital, or if they're done with the 12 lead, we're going to have them at least on telemetry, which is 3 or 5 leads. Oh, look, 3 or 5 leads. And then ambulatory monitoring is where we have physical therapy or respiratory, or we walk around with them and monitor their heart rhythm while they are walking the floor. We're also looking at oxygenation and such. So there you go. Cardiac stress testing. That I talked about in an earlier video, so I'm not going to spend a ton of time on it. But we basically are monitoring their heart rhythm and how it's working when they are exercising. If they're unable to exercise, we give vasodilating agents, which mimics exercise. Let's see. Next, diagnostic testing. This is perfusion imaging. So myocardial perfusion imaging. This is where you can see, I think in the ultrasound, you can see the blue and the red. It shows the flow of the oxygenated versus the deoxygenated blood. And you can see where you have narrowing in the arteries. PET scan. Test of ventricular function and wall motion. CTs. Everything on this slide is nice to know, by the way. Not need to know. Echo, we already talked about it. And these two things right here are just different views. And they show different structures. And cardiac cath, we also talked about. So if you have a heart attack and they suspect that there's a blockage, then they do the cath lab to evaluate it, and then they put in stents. And if that doesn't work, then open heart surgery is the next step. I feel like that's enough. It's probably more than enough. Thanks for tuning in.